A 7 years old male child born out of non-consanguineous marriage brought by mother from Varsanadu, whose informant is mother and reliability is good, with the complaints of delay in attaining age-appropriate milestones since early infancy. As the symptoms are suggestive of developmental delay, I would like to start my history from antenatal period itself. The mother was married at the age of 25 years and it was a non-consanguineous marriage. Her first pregnancy, full-term female baby, birth weight was 2.4 kg, cried immediately after birth with no NICU admission. The second pregnancy is a present child. The mother's age at the time of conception was 29 years, and inter-pregnancy interval was 3 years, and pre-pregnancy BMI was 21, and weight gain throughout the pregnancy for the mother was around 10 kg. First trimester, it was a spontaneous conception, and pregnancy was confirmed by urine pregnancy test at 6 weeks of amenorrhea. Dating scan was done at 8 weeks and was corresponding to the gestational age. Mother was booked and immunized at private hospital Madurai. Folic acid supplements were started, and no history of fever with rash or excessive vomiting or drug or radiation exposure. Second trimester, quickening was felt at 5 months, and oral iron and calcium tablets were taken by the mother. An anomaly scan was done at 22 weeks and was said to be normal. No history of pregnancy-induced hypertension or gestational diabetes mellitus or bleeding per vagina. Third trimester, growth scan was done at 7 months and was said to be normal. No history of blood transfusion in the mother, and no history of gestational diabetes mellitus or pregnancy-induced hypertension or bleeding per vagina. Her EDD was 1/3/2015. The mother had labor pain and spontaneous rupture of membrane at around 34 weeks of gestation. No history of foul-smelling liquor or burning micturition. No history of maternal fever during labor or delivery. And labor pain started at around 1 p.m. and the mother was admitted around 2 p.m. and had spontaneous rupture of membrane after 2 hours of labor pain. So the labor duration was around 5 hours and the baby was delivered at around 6 p.m. on 12/1/2015. The natal history, the baby was delivered at around 34 weeks of gestation in a private hospital, Madurai, by labor natural. No meconium stain liquor. Baby had a weak cry after birth, but the resuscitation details was not known. The birth weight of the baby was 1.5 kg and the baby was shifted to Madurai GRH in view of respiratory distress within 1 hour of delivery. Cousin in ICU, the baby was admitted as a case of preterm low birth weight respiratory distress since birth. Surfactant administration was done and the baby was under mechanical ventilator for 4 days and then was weaned to oxygen hood and was on oxygen support for 3 days. The baby passed urine and meconium on day 1 and was started on tube feeding on day 7 and gradually EBM feeds were started on day 10. The baby was started on DBF on day 12 and baby was with mother since day 12 of life. Baby was discharged on day 16 and continued to be on DBF. No history of seizures or no history of any jaundice during the time of admission. The total duration stay was 16 days and discharge weight was 1.6 kg. After discharge, the child was continued to be on DBF and was taking feeds well and was in regular follow-up till 4 months of age. During those visits, child was screened for ROP and OAE and was said to be normal. And after that, they lost to follow-up. So, coming on to the developmental history, the child attained social smile at around 4 months and the child was able to turn head towards the sound and able to follow mother at around 4 months. And 5 months, the child started to recognize mother and had cooing. The mother noticed that the child was lacking head control by 6 months. That was the time which the mother noticed. And the child attained head control by 7 months. And 8 months, the child was able to reach for object. And 9 months, the child was able to speak monosyllables. By 1 year, the child weighed bye-bye. And around 1 to 1.5 years, the child started to sit with support and was able to have a pincer grasp and turns when called by name and had eye contact. Around 2 years, the child started to sit without support and spoke 1 to 2 words. By 3 years, the child started to scribble and was able to speak 2 to 3 word sentences. By 4 years, the child was standing with support and was able to copy a circle and and can ask for food and toilet. At 5 years, the child started to walk with support and is able to know the gender and able to interact when he was asked. At present, the child is able to walk with support. and the child is able to interact and tell some few things which he was taught. And now the child has started to go to school, and he has started to write. And this is a Tamil medium school, and he has been taught of writing this alone. History of stiffness of limbs noticed by the mother at around 6 months. And there was a history of difficulty in changing diaper, and history of difficulty in placing the child over mother's hip. Mother then took the child to a nearby physician for the above complaint at around only 3 years of age, and the child was advised to be on physiotherapy. The child was given physiotherapy only for 2 weeks, and then they discontinued. Now, after 3 years, they have resumed physiotherapy for the past 1 month. When child has been sent to school only for the past 2 months, when asked simple questions which we come across in day-to-day life, child comprehends well and answers them appropriately. Since he has not been given any schooling, he is not able to answer questions that need general knowledge and mathematical skills. The child is able to now raise his arms above the head, and he is having his mixing his food himself. And there is no history in difficulty in turning in the bed, no history of difficulty in sitting from the supine position. He has difficulty from getting up from the sitting position. He needs help to get up from the bed, and he has a difficulty in climbing stairs and walking with the slippers. He has no excessive sleep or altered behavior. No history of difficulty in smell perception or vision, and there is no history of drooping of eyelids, and he is able to chew his food, and there is no deviation of angle of mouth, and he is able to turn around when he is called, and there is no difficulty in swallowing, or while feeding there is no nasal regurgitation, and there is no deviation of tongue. He is able to appreciate cold and hot water while bathing, and there is a cry during IV cannulation. There is no involuntary movements, and bowel and bladder control was attained at around 5 years. And there is no history of constipation or bed sores or abdominal position of the limbs, and no history of seizures, or no history of dental caries. So, immunization history: the child was immunized according to age up to national immunization schedule. A dietary history: the expected calorie intake is 1,580 kilocalories, but the child is taking only 780 calories with a deficit of 800 kilocalories. And protein intake expected to be 22 grams. The child is having only 13 grams with a deficit of 9 grams. A family history: he has a sibling who is now 11 years old. There is no developmental delay in the sibling. The child is going to school, her academics is good, and there is no developmental delay in other persons in the family or death in the family. Socioeconomic status: a Kacha house with the 2 rooms, the separate kitchen with a separate bathroom. Father's occupation is a semi-skilled worker. Mother is a housewife. Father's income is 1,500 and per capita income is 3,750. According to modified Kupasamy scale 2021, that comes into lower middle class family. And contact history: no history of contact with TB. So summary: this is a 7 years old male child, born out of non-consanguineous marriage, with a significant NICU admission for prematurity, presenting with global developmental delay, with stiffness of all limbs and weakness on the lower limbs, with a normal vision and hearing. I would think in terms of a non-progressive motor disorder, mostly a cerebral palsy with a spastic diplegia type.
Okay. Just before this thing, I appreciate the history, the way she is presented, because many people make a mistake, delayed milestone from birth. Nobody can make out, but she mentioned early infancy. I appreciate that statement, and she has presented very well. My appreciation, sincere appreciation to the student.
Thank you, sir.
Okay, there are 2 things. In the newborn history,
Yes,
you focus on history of lethargy, seizures. What happens is, usually they may not tell you about neonatal history of hypoglycemia. They can manifest as either lethargy or seizures. You just ask specifically. Why? Because in the examination, you are going to ask for vision. So usually what happens is cortical visual impairment may be missed by history. They may not say. So if the history is there of neonatal hypoglycemia, you just anticipate cortical visual impairment, because the occipital cortex is a metabolically active area which gets damaged, whether in all symptomatic cases and in some asymptomatic cases. So you just focus your attention on that.
Okay.
And then history of NICU stay, if it is more than 3 weeks, think of meningitis.
Okay, sir.
That is also one more thing. So in this child, so your diagnosis, see, at the end of the history, you should answer these questions. Is there a lesion? What's the level of lesion? What's the nature of lesion? These questions should be answered at the end of history in every neurology patient. See this child, you just tell me, why do you say so it's a spastic diplegia? And why do you say it's cerebral palsy?
Sir, the child is having for cerebral palsy, the child is having a developmental delay, which is a non-progressive nature, sir. And in case of a spastic diplegia, the weakness will be more in case of a lower limb, and the preterm history is more significant for a spastic diplegia, as there is a periventricular involvement in case of a spastic diplegia. The child is able to interact. He is not like a child. He is able to tell whom they are, and he is what and all day-to-day activities. So I think he has an intelligence is not more affected, sir. So it may be a spastic diplegia.
So you are telling points for diplegia. What for spasticity?
Sir, the mother has given a history of stiffness of the all lower limbs, and diaper changing has been difficult, and the mother feels difficult while holding the child.
It's a tone abnormality. Yeah.
Yes, sir.
Good, you brought up the low birth weight, history of difficulty in diaper changing, spasticity, IQ, mentation normal, no seizures. That is important. Quadriplegic CP, the
Yes,
seizures are more, and mental retardation will be more. So probably spastic diplegia. So what do you expect in your examination?
Just can I just
yes, please, sir.
see, Dr. Nikita, you have assumed that what is the etiology of this child?
Sir,
The etiology of his the cerebral palsy.
So it's mainly because of a preterm, sir, and because of a respiratory distress, the child had an NA6, mainly because of that preterm history, a perinatal insult, sir.
Okay. Just a bit of, I just want to, I don't know if I should interrupt now or I should tell you later. I think, see that currently, if you look at the neonatal care in Tamil Nadu particularly, is extremely good. So you cannot assume that low birth weight will cause cerebral palsy. You have to be very careful about that point. So because actually you can look back at data. The data is quite for cerebral palsy out of low birth weight, especially with 1.5, is actually quite low. It's less than 10%. So don't assume that this is just low birth weight related things. The other thing I want to just say in the history, see, you have mentioned you went from neonatal history straight into the developmental history. Now there are certain times that's what usually people make a mistake, and there are certain things which we need to know. Now the first thing we need to know is, so I think that was because of the assumption that you assumed that this is directly low birth weight, but I think you should always wait for that thing. You shouldn't make that assumption. See, we want to know first thing is between the neonatal discharge is maybe around a month. Was it a month?
Sir?
Was the child in nursery for a month?
No, sir, for 16 days, sir, for 2 weeks, sir.
Okay, so it's 16 days. So you said 16 days, and then your next history is picked up at 4 months, right? That when your development starts. Now you have actually missed 2.5 months in between, a very crucial period. So what do you think should in this now, if this child has already started, I think the first mention of what is the first milestone you mentioned?
So social smiles, social smiles.
So you are mentioning social smile at 4 months, right?
Yes, sir.
Is that what you said? Okay, right. Okay, and remember you're taking the history at 7 years of age. So this is most of it will be, and I'm sure this child would have gone to multiple doctors, and obviously the history would have been doctored many times. So there are certain things you need to ask between this period of 1 to 3 months, which you have not written anything. It's very important. One of the things would be the child will have incessant crying. The mother goes back, the child keeps crying at night, especially at night, mother cannot sleep. That is probably because the child is developing spasticity. That is before the child develops, all this thing about changing the diaper and all. Incessant crying is a very important history which you have to take. Second thing, obviously, there will be other histories like abnormal movements, sophistatonic posturing, some kind of, may not be a myoclonic seizure, there could be some myoclonic movements. The other thing is, when did the child actually start looking at the mother's face? Was that delayed? Now, at 7 years, getting all these histories is important. The other thing is, was the child very lethargic in the first 3-4 months? They go through a period of encephalopathy before they start recovering. So this is a very important, crucial period, which usually is missed by postgraduates, and it's a time when we have to concentrate. Again, I want to emphasize, do not assume Given the level of neonatal care, do not assume that all low birth rate cerebral palsy is because of very low birth rate. That is something which you cannot make that assumption. And actually, you really haven't proved that point in your history. Difficult to prove, but don't make that assumption. So you should always keep an open mind that this could be something else and not just cerebral palsy because of very low birth. I mean, now more and more we have seen that there are so many things which happen, and don't assume everything is low birth rate. So keep that. We accept that this is a differential, but this is not the complete truth.
Okay, sir.
One more thing is, whenever you're asking history, you just inquire whether the tone is persistently increased during sleep also. Because usually what happens in children with dystonia, they may mimic CP. In children with
Yes, sir.
dopa-responsive dystonia and all. So usually tone disappear, tone will be normal during sleep, or they'll be much reduced during sleep. Even while examining, you can observe some children go in for sleep at that time if you are able to move easily. And then you can say that there may be a component of dystonia in addition to spasticity, or it is predominantly dystonia. You should elicit this history also.
Okay, sir.
Okay.
Please carry on. That's all
Yes.
from my side.
Okay, sir.
And what is the level of lesion, do you think?
Periventricular area, sir.
Okay. Whether cortex is involved or not?
No, sir. Subcortical area.
Why
Sir.
not? Why subcortical?
Sir, intelligence
Another
is present
point.
and no seizures, sir. No seizures in the child.
Okay.
General examination. Posture of the child is in supine position with adduction at the shoulder joint, with flexion at the elbow and wrist, with arm pronated and both lower limbs extended at the knee joint. The child is awake and alert. No pallor, no icterus, no cyanosis, no clubbing, no pedal edema. So vitals, the temperature was 98.6 degree Fahrenheit, the pulse rate 86 beats per minute, regular in rhythm, normal in volume, no special character, no radiofemoral delay, no radio-radial delay, all peripheral pulses of health. Respiratory rate 24 per minute, capillary refilling time less than 3 seconds, and SpO2 is 98% at room air, blood pressure 90/60 millimeter of mercury measured in left upper limb in supine position. Anthropometry, his weight was 10 kg, which was against the expected weight of 22 kg, which comes under the less than third centile according to IAP growth chart. And the height is 99 centimeter, the expected, which is against the expected of 119 centimeter, which is less than third centile. His BMI is 10.5, and it is also less than third centile. The head circumference is 43.1 centimeter, which is against 52 centimeter, which is above 5 years, it has to be 52 centimeter, but it's only 43.1, which is also less than third centile. So head to toe examination. In head, child is having only a microcephaly, no dysmorphism noted in the face, no drooping of eyelids, or no deviation of the eye. Ear, no deformity, and in the nose, normal. Mouth, no dental caries, no glossitis, no cheilitis, no swollen gums. Chest, no deformity, no rachitic rosary, no bed sores, no neurocutaneous markers, and spine is normal. CNS examination. Higher functions, the child is conscious, oriented to time, place, and person. The speech, a comprehension is normal, his fluency is normal, and repetition is normal. Memory, his working memory, recent memory, remote memory is intact. Intelligence, the child is able to comprehend and answers to the questions which is familiar to him, but is unaware of the concepts which is appropriate for his age. Right-handedness. He is able to repeat what his mother is telling, and when asked what he ate in the morning, he was able to tell that he ate biryani in the morning. Cranial nerve examination. He was able to perceive coffee powder in both nostrils separately with his eyes closed, and he was able to look out for objects at a distance, and his visual field was normal. And color vision, he was able to appreciate primary colors. Pupillary reflexes was present. Extraocular movements, and there was no his eyeball movements was normal in all direction, no ptosis or no squint seen. His sensation of the face were intact, and he was able to clench his teeth. Jaw movements were normal, jaw drop was normal, and conjunctival reflexes was present. The 7th now, there was no facial asymmetry and there was no angle of mouth, there was no deviation, and nasolabial folds on the both sides were same, and he was able to perceive the taste sensation over the 2/3 of the tongue. Rennie's and Weber's, Rennie's air conduction was more than the bone conduction, and Weber's no lateralization. 9th and 10th, palatal movements and uvula were normal, and uvula seemed to be in the midline. He was able to swallow the food. 11th now, he turns the head to opposite side. It was normal power. There was no wasting or drooping of shoulders. 12th now, the tongue bulk tone was normal, and there was no deviation of the tongue. Motor system inspection, thinness was seen in both lower limbs, and bulk in the right arm was 14 centimeter, left arm 14 centimeter, forearm 12 centimeter, and left 12 centimeter. In the right thigh was 23 centimeter, and left thigh was 23 centimeter, and right leg was 15 centimeter, and left leg was 15 centimeter. The tone in upper limb in the arm right side, the tone was slightly increased, and the left side was slightly increased, and forearm was also slightly increased, and left forearm slightly increased. Lower limb thigh was increased, and then left thigh increased, and leg right leg was increased, and left leg also increased. She tone was increased in lower limb more than that of the upper limb, and it was in spastic type of hypertonia seen in all limbs. Power, it was a shoulder joint flexion, extension, adduction, and abduction. The power was around 5/5, and elbow joint flexion extension is 5/5, and in case of wrist joint flexion extension was around 5/5. So normal power was noted in case of an upper limb, and in hip joint flexion extension, adduction, and abduction was around 4/5, and in knee joint flexion and extension both right and left was around 4/5, and ankle joint dorsiflexion, plantar flexion, inversion, eversion in both right and left was around 4/5. The reflexes, superficial reflexes, abdominal reflex was normal, cremastic reflex was normal, plantar was extensor. In deep reflexes, in the right biceps was normal, and left biceps was normal, and right triceps was normal, and left triceps was normal. Supinator, right supinator normal, and left supinator normal. And right knee jerk was exaggerated, and left knee jerk was exaggerated. Ankle jerk, right ankle jerk wrist, and left ankle jerk wrist. There was no ankle and patella clonazine. Plantar extensor type, and was an exaggerated. No primitive reflexes. The sensory system, he was able to all sensations, touch, pain, temperature, vibration, joints, and pressure was intact, and cortical sensations was intact. Cerebellar system, no ataxia, no nystagmus, no dysmetria, no intention tremors. Spine and cranium, normal. Other system examinations, cardiovascular system, first heart sound and second heart sound here, no murmur. Respiratory system, bilateral air entry present, no added sounds. Abdomen, soft, non-tender, and no organomegaly. So summary, a 7-year-old male child born out of non-consanguineous marriage with a significant NICU admission for prematurity with global developmental delay, with the significant findings of microcephaly, spasticity in all limbs with exaggerated deep tendon reflexes in the lower limbs with chronic malnutrition. Diagnosis, the case of spastic cerebral palsy, diplegia type with gross motor functional classification scale 3 with mild intellectual impairment, most probably due to an perinatal insult of prematurity with normal vision and hearing with chronic malnutrition.
Well said.
I have a few points clarifying your examination. You said Rennie and Weber was done. 7-year-old child Rennie and Weber, I don't really think is possible, but I could be wrong. But I don't think it's possible. And let me ask you, Dr. Nikita, what do you think is the best test to check hearing?
Sir?
What is the best test to check hearing?
Bera, sir.
How do I know if you're hearing or not?
Sir?
How do I know that you're hearing?
Sir, I'm responding.
That's precisely the answer. If the child is answering your questions, he is responding.
Yes, sir.
You must remember, BERA does not go up to the cortex. It goes only up to the brain stem. So it is not the best step. The best steps for hearing is the child gives you the right response, a cognitive response to your question. That's the best test. So if the child was just answering what you are asking the question, whatever he asked, you said he had biryani in the morning, that is good enough to know that the child is hearing. And I don't think you can do a Weber and Rennie at that time. It's right. It's quite a complicated test, lateralization. So I'm not so much clear whether that was correct. A few more questions I have is, can I continue or somebody else wants to?
Yes, sir. Continue, sir, please.
This question, I know Dr. Mahesh is here, so he can also clarify for me. You told me the power, what is the power of the upper limb?
Power of?
Okay, the power you said is your upper limb, all the power is grade 5, right?
Yes, sir. Yes, sir.
You told me the muscles are all spastic, right?
Yes, sir.
So I stand that I asked Dr. Mahesh if I'm right. I don't think a spastic muscle, as far as I understand, is a weak muscle. You cannot get grade 5 power. Is that correct, Dr. Mahesh?
Yes,
Sir,
sir.
but his spasticity in the upper limb was only slightly increased, sir. So
Yeah,
he was
but-
able to.
No, so you have to be very careful before you make a statement like that, because spasticity itself means that the muscle is weak. So when you commit yourself to grade 5 power, it's a rather dangerous situation. So I would say, maybe I would say I'm not so much, I cannot really believe the power is grade 5, because you have said on the other, it is sort of contradictory. It's a contradictory statement that the tone is increased and the power is decreased. Yes, I think Dr. Ramasubramanian, you wanted to say something?
So here the power was almost, the upper limb was almost normal. Maybe the spasticity part, we are having some doubts.
No, sir, my point was not, my point was not the clinical examination. My point was,
Okay.
sir, just to tell this principle, neurological principle. I mean, I'll ask Dr. Mahesh.
There may not be any spasticity then,
Yes.
actually.
Yes, sir. It was maybe.
No, just that so that is a thing. That's all I'm saying, Dr. Nikita. I'm not saying that your examination was wrong. What I'm trying to say is, when you say spasticity, don't say grade 5 power. It will not. It is unlikely, because spastic muscles are.
Yes, the reflexes were also normal in this child, sir.
So that is just a point that I wanted to say, because you know, it's a contradictory statement. That's all I'm trying to say. Spasticity increases, power has to decrease. So that's the thing. I'm not, so I just wanted to make that point, because a spastic muscle, as far as I know, is always a weak muscle. You can have a hypotonic muscle which may have normal power.
Yes, sir.
For example, in Down syndrome, it's a hypotonic child. You can have a normal power. But a spastic muscle is a weak muscle. That is sort of contradictory when you say grade 5 power and spasticity. So either one of that you have to change.
Sir.
The other thing is, again, things like cortical sensations. Now, the child is 7 years. Okay, I just want to go back to your beginning of your examination. That is CNS higher functions. I just want to say this again. Now, I see that a lot of my teachers, I have a lot of people who I have learned in this forum. So I could again stand corrected. But you know, let me say, okay, you said conscious oriented speech. Okay, now the major mistake, it was a great examination. The major mistake, what is your major deficiency in this? Did you realize that there's a major deficiency in this in your presentation? I guess it must have been a mistake. I mean, it was a accidental, but there's a major thing missing. What is it?
Emotions and behavior, sir.
Not really. It's a major mistake that you have made. The major mistake is you have not talked about the developmental assessment. That's a huge error. And the reason is because of this statement. See, when you say child is oriented to time, remember child is 7 years. We don't know what is a child's developmental age. Okay, you have to again go back and clearly say what is it. You said we could, I mean, from your history, I can pick out here and there that maybe the child's gross motor is about say about 9 to 10 months. I
Yes,
don't know
his
how
gross motor is about 1 year, sir. His sensory
So what
and
what I'm trying to say is, you have to say very clearly about the developmental assessment, and I am not very sure. See, when you say intelligence, now this is something which I always tell medical students: how do you decide the intelligence of a child?
sir,
How do you decide that this child was
sir,
intelligent?
actually, sir, intelligence is the judging power of the child. The child has to think effectively and rationally, and it has many intelligent
See,
scales has been there, sir.
So
For
which you did not do, which you did not do. So you really cannot say the child is intelligent. So the point which I'm trying to say is this. First of all, this mnemonic comes from this high combs, right?
yes, sir.
Which is actually a ridiculous mnemonic. It doesn't make sense at all. Because if you go by highest function test, your highest function is handedness. Handedness is really not the highest function, isn't it? It's a much, I would say the first thing you should talk about, what you have done is correct consciousness orientation. But then I think the next thing, how do you decide if a child is intelligent, is to do a developmental assessment. Now, if a 7-year, if you tell me that this 5-year-old child corresponds to another 5-year-old child, I know he is, I cannot say if he's intelligent or not, but I know if he's developmentally appropriate or not. So this is what I placed before my seniors here. Should the developmental assessment be equivalent to intelligence? Should we say that is the intelligence of the child? Because that is a much more objective assessment than this rather vague statement about comprehending. This is what I'm asking. I just asked I asked, maybe I can only say Dr. Mahesh and Dr. Ramasubramani. If there's anybody else, what do you say? Dr. Srinivasan is there. I mean, I can't see the
Yes,
others.
sir.
Do you agree with me, sir, that instead of intelligence, that should be the a detailed developmental assessment of the child?
Yes, sir. Dr. Ramasubramanian, sir.
Sir, so that's what in examination, is it the stipulated time, is it possible for us to do a detailed development assessment? That's
Dr. Uman,
because
after 3 years, I think we normally talk about intelligence more than development, because I don't know whether we can use the word developmentally normal in a 7-year-old. Having said that, I think it's not possible to examine the intelligence also in a clinical exam without standard tools.
yes,
I mean, the way she has looked at the child's intelligence, I cannot accept, because it requires a lot of things you should put together before you say whether the child is intelligent or not. And asking for remote memory, working memory in this child, I really don't know. I think she can just say that this child was able to answer simple questions and say his speech was normal. That's all. I really don't know whether she can comment on the child's intelligence.
She can.
Yeah, I do agree with Rama. I don't think she can, do so many aspects of memory testing in this child. Yeah.
And I think in higher function sleep also we will have to mention, because majority of the developmental delays or children with problems, they have problems with sleep, which may not come in any other part of the examination. I think that also will be included in a higher function.
Okay, ma'am.
Sir, I agree with Professor Samuel, because it is not possible to assess intelligence in a very young child like 2 years infants. So indirectly, we use the developmental assessment as a means of assessing the intelligence. And as you rightly said, it is not enough if you just take the developmental history alone. Many of the postgraduates don't do a assessment per se. You have to do it in the examination also with the objects that you have for developmental assessment. Then only you will be able to correlate with the history. I agree with you that 80% it is based on history and 20% on clinical examination. Thank you, sir.
Thank you, sir.
And Dr. Nikita, one simple question. How will you differentiate the spasticity from rigidity in this child?
Sir, velocity dependence, spasticity will be, rigidity will be velocity independence.
Okay, how will you look for that?
Sir, in case of a passive movements, the spasticity will be increasing.
So you should do rapid movements over a major joints. And then in case of rigidity, you just choose supination pronation. You should do it slowly to find the rigidity, otherwise you will miss the cog
Yes,
wheeling. That is one thing.
yes,
And
sir.
then what about the adductor spasticity of the hip in your patient? You said difficulty in changing diapers and all.
Yes, sir.
After examination,
Yes, sir. Yes, sir.
is it significant or not?
Sir, yes, sir.
And then show me the video which you showed in the history stage. The child,
The posture.
child was
Posture,
having
that
a
for-
broad-based
that
gait.
But there were
Right.
no scissoring and also only there was
That's right.
spasticity. Sir. But
Okay.
that
Are
much.
there any
adductor-
ataxia?
No, sir. No
No,
ataxia.
no.
Sir. No, sir.
Okay.
Just Dr. Nikita, just take off from Dr. Mahesh's question. There was no spasticity, right? That's what you said. I mean, there's no scissoring. Sorry, there was
No scissoring, sir. Yes, sir.
Okay. I don't know. Can I ask a question regarding investigations here, or do we wait for her to talk about the management?
Yes, sir. You can ask. Yes,
Okay, I
sir.
have just one question. What you said, this child probably had periventricular leukomalacia. Isn't that what you said?
Yes, sir.
Okay. So now from periventricular leukomalacia, because you assume that because of the low birth weight. Okay.
And because of his cortical function preserved, sir, no seizures, and he was not
Okay,
that much.
fine, that's fine. I'm not going to that. Now, that is a bit of this is again something which periventricular leukomalacia can present with just global delay, so you may be completely right. But again, I just think usually if there was PVL, the child would have spasticity, he would have scissoring, obvious scissoring. And so that is one thing which again you have to, I mean, this is to put back the thing. Second thing is head. You mentioned the head circumference was 43 centimeters.
Yes, sir.
The expected for age is 51. Is that right? What you said?
Yes, sir. Yes, sir. Yes, sir.
Okay. Again, there I would be very careful because periventricular leukomalacia usually does not have so much of volume loss.
Yes, sir. Yes,
It
sir.
would be more of a cortical volume loss. I mean, something like a cystic encephalomalacia or encephalomalacia of some kind. And so that is another thing which is not wrong in anything that you said, but you should keep that in mind later that this may not be periventricular leukomalacia. Two things. One, head size is quite small. And second, there isn't any scissoring. So that's one thing I would just keep in mind before I commit to periventricular leukomalacia.
You showed me the video, you showed some video in the history stage.
Sir, video in the.
In the history, this is not
Yes, sir. Yes, sir. Yes, sir.
here.
Yes.
The child's tanks is
Sir.
child was walking with support, isn't it?
Yes, sir. Yes, sir.
Start with a broad based gait. If there is significant adductor spasticity, it may not keep this posture.
Yes, sir.
100 150 200
You're sure that the child was
Okay.
spastic?
Yes, sir.
Is it spasticity or dystonia?
Sorry, okay.
No, sir. Was spastic. Spastic.
Okay. Okay. Suppose if I say, leave on the clinical picture. If I say this is a hereditary spastic paraparesis, so will you agree or disagree? How can you defend your point?
Sir, can you repeat it, sir?
Suppose if I say this is a child with hereditary spastic paraparesis, will you agree or disagree? Just a question. You are not saying this is.
Sir,
Static. See, in HSP is progressive. Whenever the child presents with spasticity, you ask definite questions to rule out progression. You just ask the mother whether it's progressing or not. It's not progressing, static. That is one thing. Number two, if I say this is dopa responsive dystonia, will you agree or disagree?
so there will be that in dystonic CP, then there will be a tone will be variable.
I'm not saying dystonic CP. Sometimes what happens is dopa-responsive dystonia, the lower limbs are more involved. So usually there will be a diurnal variation, there will be fluctuation. So you should take care, you examine the child in a careful way. As I already told you, there may be fluctuation in the degree. So whenever you start examining, child may be having stiffness. So after some time, there may be there may not be any stiffness at all. So that is fluctuating tone. That may be a dystonia. So you should be able to examine the child in a careful way. Okay, proceed.
Okay, sir.
Okay. So at the end of the history, at the end of the examination, so the child is having, what are the structures involved?
Sir, a periventricular area region is involved, sir, with this lower limb more involved than the upper limb, sir.
Nikita, going back, please don't commit to periventricular region. There is from the clinical examination, there is no evidence to say periventricular region is involved, because like Sir Dr. Mahesh said, the child is walking with a white stance. So you may finally find it as periventricular region, but I wouldn't comment on that. I wouldn't commit to that right now.
Okay, sir. Okay, sir. Okay, sir. Sorry, sir.
Any questions, Dr. Ramasundram, sir?
Any regarding this preterm, what are the neurological complications a preterm child can go in?
So the child can have an intraventricular hemorrhage, sir.
Okay.
Then seizures can occur, sir. Hypoglycemia, metabolic seizures can be because of hypoglycemia-induced seizures, sir.
Okay.
Then hypocalcemic seizures can also occur, sir.
Okay.
Sir, other complications like bronchopulmonary dysplasia.
No, not the neurological complications.
Okay, sir. Okay, sir.
They can go for perinatal depression.
Okay, sir. Asphyxia, yes, sir.
Perinatal asphyxia they can go in for. Okay. So any drug to the mother that could have prevented or that has some benefits for the before the delivery?
Yes, sir. Magnesium sulfate, sir. Antenatal magnesium sulfate and antenatal corticosteroids. Magnesium sulfate 4 gram loading dose over 30 minutes, followed by 1 gram per hour infusion. Could have been given in the mother, sir.
Okay. So,
Dr. Nikita, very basic question.
So you said in your history, this child has it lost follow-up after
Yes,
3 or 4 months, and then it came back only after 3 years.
Yes,
so
sir.
What happened in between? What actually happened?
Sir, actually,
the child was not taken anywhere into any healthcare facility, even for immunization, or immunization should have been given.
Sir, yes, sir, the mother went for immunization, but the mother itself noticed that the child was having spasticity around 6 months. Sir. So until 4 months, there was no issue with the mother was telling. And
so
another thing,
after noticing spasticity, she didn't go anywhere.
So no, sir. The nearby neighbors have reassured the mother that as a child is a preterm, it may be having those things. It will settle on its own. We can give allowance for that for some duration. So the mother was also convinced by that, and she never took, sir. Once after 3 years only, she noticed that the child was not able to do so and so activities, and then she took to nearby physicians, sir.
Okay, the nearby people should have gone for immunization or other thing.
Sir, but the mother was telling that.
Is it not?
Yes, sir.
To some healthcare facility or by some health worker, even there, they have not told anything to
No,
them.
sir. Yes, sir. No.
Okay.
Okay,
so from your history, can you tell what are the early markers of cerebral palsy that is present in this child, which if addressed at that point itself could have prevented the present condition, the child would have improved?
Sir, the falling sentence of head circumference, maybe.
No, history cannot say falling sentence of head circumference. You cannot identify in your history.
Social smile was not attained. So lack of alertness in the.
Okay, the initial stages. Okay.
Yes, sir. And persistent tone abnormalities and difficulty in changing diaper.
Okay. So persistent. Social smile was delayed and persistent tone abnormalities, which were present in this child,
Yes, sir.
but not taken into,
Yes, sir.
but not addressed properly. Okay. So even then, if it had been identified earlier and treated, could have the child would have been better now. Okay.
Yes, sir.
Okay.
Dr. Nikita,
Yes, sir.
can you tell me what is cerebral palsy? I mean, just it has been 3 specific points. What is cerebral palsy?
Sir, actually, it's a diagnostic term, sir. Used to describe a permanent disorder of movement and posture causing activity limitation, which is attributed to a non-progressive disturbances that occurred in a developing fetal or infant
So
brain.
just give me 3 words. Just 3 words.
So it is a movement and posture disturbance. It's a permanent and non-progressive one, which occurred in a developing brain. Sir.
So it's a non-progressive disorder, occurs in a developing brain, and movement and posture. In
Yes,
other words,
sir.
it involves predominantly the motor system.
Yes, sir.
So that is, when you ask cerebral palsy, those are, if this child has these 3 conditions, it fulfills the condition of cerebral palsy. Actually, if you look at, there is another condition which is a little, which is not so important. The other thing which actually you did not mention, or probably, it is delayed disappearance of the primitive reflex and the delayed
And
appearance of
postural.
postural reflex. So you should, I think you should demonstrate a parachute reflex to say that it's delayed. That is one thing. But the first 3 are more important, because usually with physical therapy and usually all this persistent, the primitive reflexes usually you cannot demonstrate. How would you like to proceed now?
So actually, this is actually cerebral palsy is a clinical diagnosis, sir. So actually, MRI can be done to rule out etiological worker. And if the child has any coexisting abnormality, then we should focus on them, sir. This child needs specially of physiotherapy and special school education to improve his intellectual impairment, sir.
Does anybody else want to? Okay. See, so you said, okay, right. I mean, I'm glad. I don't know if it'll. I don't know if it's acceptable by the examiners if you go straight away into an MRI. But actually, in reality, that is the truth. You really cannot make a further diagnosis till unless you get into the MRI. You have to do a neuroimaging. And before I get into that, I just want to ask you a question. Suppose this child had come to you at 1 month of age. Could you have made, or could you have suspected cerebral palsy? Or 1 to 3 months of age, if this mother had brought this child to you, could you have suspected cerebral palsy?
Yes, sir.
Let's assume that you have everything in the world. You have all the money in the world. You have all the facilities in the world. Actually, it doesn't have. Now, almost all the hospitals have all these facilities. Can you suspect cerebral palsy if this child is 3 months of age? Or rather, the child can develop cerebral palsy or a developmental delay at 3 months of age. How would you think?
Sir, yes, sir. If the mother gives a history of that the child is having an irritable cry or a lethargy or a kuasek, and at 3 months the child has to get a social smile. And if you are doing some motor development milestones, like in case of a prone position and supine position, the child the head control will usually starts to get around by 12 weeks. So maybe along with the tone abnormality, maybe we would have identified this child at around 3 months of age.
So how do you identify the tone abnormality at 3 months of age?
Sir, Milton angle with those.
Yeah, that's correct. Carry on.
And some neurological exam.
Emil Tisson, you say you do an Emil Tisson examination, and So at 3 months of age, let's say this, what would suggest that this child is going to have cerebral palsy? Can you just using an immunotizome, what are the things which you would think that the child could have cerebral palsy?
Sir, by using popliteal angle and scarf sign, adductor angle.
Angle, do you know how much the angles would be? Let's say less than 40 degrees. If the adductor angle is less than 40 degrees, then you could start suspecting cerebral palsy. So that is one thing. Okay, suppose immunotizone. Suppose, is there any other thing now? Can we? I mean, immunotizone is quite good. Do you know any other?
General movement assessment or Hammersmith method can be used to identify this neurological screening in newborns, sir.
So what is general movement assessment? What is it?
Sir, by assessing the movement of the child, we could assess, sir, and it has a sensitivity of around 98%, sir.
So how do you assessing what movement? See, the thing is, general movement assessment is a very specific kind of an assessment. So it has requires special training. But the fact is, if you look at it, I think most experienced pediatricians would be able to make it. If the child is able to move his limbs up and down, there's reciprocal movements of the hands, limbs flexing well, then you know that the child is probably normal. Okay, so general movements, of course, it's a very specific kind of a movement assessment, which probably requires some training. Other thing is, do you think an MRI at that age would have, suppose you had would you do an MRI at 1 month? If the mother comes and tells you, see, my child is low birth rate, I don't know, I mean, let's say it's a rich, I mean, now you have all these parents coming and telling you all these things. At 1 year, at 1 month, they want to know if the child has cerebral palsy. So what would you do? Let's say 1 month you want to know. This mother was a rich mother. She would come to you and say, will my child develop cerebral palsy?
Sir, actually, after 3 weeks of any insult, we would have, if we do an MRI, it at least takes around 3 to 4 weeks, sir, to identify the pattern of the injury, sir.
What about a cranial ultrasound?
So cranial USG also can rule out IVH or periventricular white matter. The volume loss could be seen in case of an cranial ultrasound also.
So the cranial ultrasound is actually a very good tool, especially serial cranial ultrasounds can give you a good clue whether the child will develop if you have porencephalexis or IVH and then all those things. Yeah, so that would be a very serial ultrasound is probably one of the best cost-effective ways of doing it, coupled with probably an immunotizone or maybe a Hammersmith. If you do this in combination, you have a very good predictive value. One more question I have. If the mother asks you, now the child is 7 years old, if the mother asks you, will my child walk at 10 years? What is your answer? What is the likelihood of my child walking at 10 years? What is the answer?
Sir, if the child has started to sit by around 2 years, then the child had a good prognosis of walking at 10 years, sir.
I don't think that is any more. I think we have to be more specific than that. You did mention a measure which could predict walking. You mentioned it in your, I think in your diagnosis you mentioned it.
Sir, gross motor functional classification, sir.
Yeah. So what is the value of gross motor functional classification?
Sir?
What is the value of gross motor functional classification?
Sir, it has 5 grades, sir.
Yeah, I mean, what is the value? Don't tell me the grades. What is the value of it? So the thing is, the gross motor functional classification is very robust. In other words, it doesn't change much. Okay, if the child has got adequate therapy, it doesn't change much. So a child at GMFCS 3, at best, may go up to GMFCS 2, but at 7 years, even that may be unlikely. It probably is more likely to change when the child is younger. 7 years, it's unlikely to change much. So the child, there is another thing called gross motor functional measure, which goes along with the gross motor. And there are some papers which show you can actually plot plot the GMFCS and GMFM, and that will give you a good idea if the child will walk or not. What is the possibility of walking? Now, this is longitudinal study, so it is better than saying that at 2 years, if the child says the child will walk. These are all things which anybody can do it, because it's all easily available now. So that is something which you should think about when you say so GMFCS and GMFM scoring. So I don't think this child will walk. Do you think the child, if he starts walking, can it worsen walking? Let's assume that he doesn't have any problem. Will the child's walking worsen?
When, sir? Now?
At any time in life. Okay, the mother says the child has started walking. Do you think it can worsen?
Sir, if the child is having contractions, means
No. He's going through regular physiotherapy, is all right, but can he worsen? The answer is possibly there could be a possibility, especially around the time of puberty, when the weight of the child increases, the upper body weight increases. The child who is walking can start crouching, and his weight and his walking can come down. So that is a very important point that you have to tell children to maintain their weight, because increased weight actually can decrease your walking. So there is a possibility the child can deteriorate in spite of good therapy. So that is a possibility which you have to remember.
Okay, sir.
And again, is there anybody who wants to speak? I'm just asking because nobody is there.
So, any other candidates? Two more candidates are there, I think so, apart from Nikita.
Yes, sir.
So are they? Tell me, how do you manage this child? He's 7 years old. He is walking with, suppose you said his GMFC is 3, and you said his intelligence, I mean, he can write some alphabet. You've written an alphabet. How do you manage this child? I mean, 1, 2, 3, 4, what would you manage? This is not a trick question. It's a very straightforward question.
Hello?
How do you manage this child? 1, 2, I mean, 4, 5 points. How do you manage this child?
Physiotherapy. Hello. Am I
Yeah.
audible?
No, how do you manage? Okay, this child is okay. So you said, see, in your diagnosis of cerebral palsy, cerebral palsy, you said child has got it's an upper motor problem. So you have spasticity, you have loss of power, you have loss of function. So you have to manage in these 3 things. So the first thing was, if you're going to look at it, you have to manage the spasticity. How do you manage the spasticity?
Hello.
Hello. Hello.
Hello.
I can hear you, Nikita.
Hello. Hello.
Yeah, you're audible. Hello. Nikita, can you hear me?
Yes.
So, how do you manage spasticity?
Sir, physiotherapy is...
Hello. Hello. Well, physiotherapy can be given to this child, sir.
No, as a doctor, how would you manage spasticity?
By drugs, sir. By giving drugs, sir. 3 drugs can be given, sir. Baclofen, dantrolene, and diazepam can be given, sir. Diazepam in the dose of 0.01 to 0.3 milligram per kg per day, sir. Baclofen in the dose of 0.2 to 2 milligram per kg per day, sir. And dantrolene in 0.5 to 10 milligram per kg per day, we can give drugs, sir. And botulinum toxin can also be given to release spasticity, sir. Dosage is 12 units per kg dose, should not exceed.
Okay, right, fine. Okay, so you can give drugs. What is the first? So you can give antispastic drugs. You said baclofen, clonazepam, tizanidine. Lots of them are there. Not just 3. There are lots more are there. So any of those drugs you can give. So that is one thing. Management. First thing is medical management with drugs. What are the other things? The second thing would be to use orthotics, ankle foot orthosis, especially. That is also a tone, what we call as tone inhibiting splints, which you may have seen children walking around, those L-shaped kind of things. Okay, tone inhibiting splints. Okay, you could give Botox. But you should also remember, Botox sounds very nice, but there are enough studies. Yeah, but there are studies which have shown that repeated Botox actually reduces the muscle power. So that is something which you have to be very careful about giving Botox. So these are things. There are some places which they give intrathecal baclofen and all that. I mean, I don't know. I don't know if Dr. Mahesh knows, but in CMC we don't. Here in CMC we don't have that, sir. And probably in Apollo they may have that.
Not for regularly for spasticity in children. One thing, and Botox after 3 or 4 sittings, you have to change. Sometimes they may develop resistance to the drug, so it may not be effective at all. Yes, that's why as the frequency increases, the interval between the dose decreases. You should also keep it in mind.
Then baclofen pump is another thing. So these are all for medical management. Then yeah, so why do you do physiotherapy for children with cerebral palsy?
Neuronal spasticity is the basis of neuronal plasticity.
Physiotherapy helps in, I'm not sure, but I don't know if that's correct. See, basic physiotherapy.
Control muscle strength.
Yeah, so basically 2 things.
Spasticity.
Yeah, reduction of spasticity and increasing the power. These are the 2 reasons why you do physiotherapy.
It helps in motor control and coordination.
Yeah, so it helps in coordination as well. So those are things. So first thing would be management of this child would be management of spasticity with medicines or with tone inhibiting splints, maybe baclofen. I'm not sure about Botox yet, and definitely and physiotherapy. So that is treatment of spasticity. The next thing which you have to treat is the decreased power of this child. The power of this child will be low, so that has to be treated. And the only thing which can actually treat the power is physiotherapy. Anti-gravity physiotherapy. That is the only thing which treats the power. The third thing which you would need to do is management of his functions. Obviously, he will have some functional disability. We have to look at what functional disability, and which is why it is very important that we have to do a developmental assessment. In fact, if you ask me which is the most critical thing in your examination, it is the developmental assessment, because that is what actually decides what we are going to do with the child. So when we and we must remember, these are not just random things that we're doing. We're actually doing it with a purpose. So everything that we do has a purpose. So unless you do a developmental assessment, you want to know what is the motor status of the child, then you can plan for you can map motor rehabilitation. You want to know what is the language abilities of the child, then you can think about whether the child will the child require whether he needs speech therapy, auditory. Sometimes he may not be speaking, so he may need to have, especially if you have perisylvian lesions in the brain, you may need to use alternate communicating devices. You may have to use gestures. So you have to decide of speech. That is why it's very important to a speech assessment in your developmental assessment. Then you have to, and your learning assessment, what this child is going to learn, at which level is he going to learn, we have to decide based on your assessment. And actually, all these assessments are all clinical assessments. You don't need any psychologist or anybody to do it. You can do it at the bedside. And then you can actually tell the parents, see, the child is at the 2-year-old level. So we are going to start at this basic concepts level. We're going to teach him colors. We're going to teach him shapes. And this is what you should be doing. So if you ask me, Nikita, that was a major deficiency in your history. I do accept that in an examination, you may not have time for a developmental assessment. Actually, developmental assessment takes only 5 minutes. And you can actually as you're taking the history, you can actually look at the child and you make your developmental assessment. You don't need to really do anything. You walk into the room, you just give the child a paper and some pen. So you can watch the child writing. You give him some, you can ask him you can see how he interacts and talks with his parents. You can, from that, you can make a thing. There is another assessment which you have to do is assessment of his play pattern. I don't want to go into that for lack of time, but that's also a simple assessment which can be done at the bedside. So if developmental assessment is the most important, crucial part of your examination, I think after basic neurology examination, then I think developmental assessment should be done, because that is actually what decides the child's future planning in this thing. Yeah, that's it from me.
Regarding this treatment part, will you give before treating? You want to do something else, which is very important in this child.
Sure.
Meaning before treatment, because they have lost follow-up and they have come to you.
Family counseling is more important, sir. We have to
Yes,
counsel
because
the parents regarding his delays, and we have to tell how their follow-up and physiotherapy with early stimulation would help him reinforce his positive developmental.
Okay. You should tell them the benefits of. You should have counseled actually. Now it's a bit late only, but still. Okay. So, what are the benefits of early stimulation?
Sir, actually, early stimulation will help in a neuronal plasticity, sir, and also it will also help in improving the muscle tone, strength, and balance. Helps in improving the movement and posture, and also it reinforces positive developmental milestone in the child, sir.
One more question. How you said this is diplegia? Suppose I tell you it's quadriplegia, will you agree with me or disagree with me?
No, sir. Sir, in case of an quadriplegia, there can be a visual disturbance. The child may have seizures and mental retardation along with feeding problems. The pseudobulbar palsy may be seen in case of an quadriplegic child, and the child would have lost. Still, the child would be delaying in developing milestones, sir.
So you're telling me that this child doesn't have visual disabilities, visual problems. Is that why the child? So, so can you just, okay, sorry, can you, so the fact that he doesn't have visual problems, he doesn't have seizures, and is his upper limb involved?
I said upper limb, only the tone is slightly involved.
So then he has quadriplegia, all four limbs are involved. So
But lower limbs are more involved than the upper limbs.
I'm trying to get to a point. I'll get to a point. So number one, it doesn't mean if the child has the diplegic children can be upper limb, can be absolutely all right. Diplegic children also can have seizures. They can have
visual and learning disabilities.
They can have cortical visual impairment. So important thing is you should remember one thing is this. When you say diplegia, you're talking about the power. Okay, you're actually talking about power. Spasticity, you're talking about tone. So you're not talking about his vision, you're not talking about his learning, you're not talking about his intellectual things. So when you're taking diplegia, you're only talking about his tone. And the other thing is, because of this confusion, I know you, because of this confusion, the current nomenclature has been changed. If you look at the Society for Cerebral Palsy Surveillance, Surveillance for SPC, Surveillance for Cerebral Palsy in Europe, they brought out a lot of papers. So the nomenclature has been changed. So according to the current nomenclature, your child may be called bilateral cerebral palsy. That would be the bilateral spastic CP would be the answer, quantified by the GMFCS level. So it will be bilateral CP, GMFCS 3. So the diplegia, quadriplegia has been taken off. I mean, we understand that. So I'm sure for the exams you can use it, but I'm telling you, because there could be always a confusion. Your quadriplegia and my quadriplegia could be different. So that's now it's either unilateral CP or bilateral CP. And then you have a dyskinetic
tone variable
CP.
And it will be a dyskinetic CP.
And
it can be again, if the tone is not variable, it can be a generalized hypotonia or ataxia. If there is
no, hypotonia is not really accepted as cerebral palsy anymore. You have to, before that would probably be the last. This is the current nomenclature. So I'm not saying for the exams you should say what I say, because hypotonia you would now will not call it CP anymore. You would wait for it. That hypotonic CP is a very questionable term, because now we know that many metabolic conditions present with hypotonia. So we don't talk about hypotonic CP unless it is a phase of dyskinesia. Initial hypotonia then goes on to become dyskinesia. So hypotonic CP is no longer an accepted thing. So in CP there is bilateral spastic, unilateral spastic, dyskinetic, which can be dystonic or choreoathetoid,
with
and
activity increased.
And ataxic. So this would be the thing. SCP It's a good paper to look up. It's a nice thing. You can just Google it, SCP guidelines, and they have given you a lot of things. You can even make out MRI changes and all. It's a very nice thing. I would strongly advise you to read that those things.
Okay, sir.
What are the MRI findings in this case?
Sir, sir, MRI findings in case of spastic diplegia or in this child, sir?
In this child.
So this child had an periventricular leukomalacia, sir. White matter injury, maybe due to was given like a hypoxic ischemic insult.
Okay.
You have PBL with no motor findings. And the child have periventricular leukomalacia with no motor findings. I mean, child is just developmental delay.
Sir, I can't understand, sir.
Can you have periventricular leukomalacia on the MRI and the child not have any motor findings? No spasticity, is it possible?
Sir, spasticity in lower limbs is increased.
No, can you have MRI findings of periventricular leukomalacia and the child not having any spasticity? Is it possible?
No, sir.
The answer is yes. You can have periventricular leukomalacia on the MRI. The child can be just have global delay. So that is something which you should know. Just because this child had periventricular leukomalacia on the MRI, I would not still be convinced that the periventricular leukomalacia on the MRI actually explains his neurological finding. Is that correct, Dr. Mahesh?
Yes, sir. Yes, sir. Not explained clinically.
Just one more question, which another thing which is actually missed, but it's a very important thing which Dr. actually Mahesh asked something later. I mean, earlier he had asked about cortical visual impairment. Do you know what is cortical visual impairment? Because it's a very, very important thing which is many times missed. Nikita, what is cortical visual impairment?
Sir, cortex is involved, which will result in blindness, sir.
Yeah, okay. See, the thing is, if you go back, see, all of us, when we were taught in our UG days, the occipital pathway ended in the occiput, right? You say the last thing which will come, the occipital radiation, it ends in the occipital region, but actually it doesn't end into the occipital region. There are two pathways beyond that. One goes dorsally and one goes ventrally. And one goes into the parietal lobe, frontal lobe, and the other one goes into the temporal lobe. It's called the ventral pathway, dorsal pathway. So cortical visual impairment is something which is seen in children with brain damage. It can be any brain damage. Periventricular leukomalacia would be a very important cause of it. And what Dr. Mahesh mentioned earlier, hypoglycemic brain injury, because the injury would be in the occipital region. So this is a very important. These children are not actually completely blind. They can look, but they have very specific behavior manifestations, and that is something which you have to look at in a child with CP, because this is missed, and so that is something which you can read up. Cortical visual impairment. I think there is a person called Gordon Dutton, D-U-T-T-O-N. You can look at Dutton's papers on cortical visual impairment, and that's a very important thing because that's usually missed.
It's not remarked.
So there are children who have come to us. I remember the reason I say this is they come to one of the manifestations in children who are not so compromised is that the child will not do well in school. He will not be able to see the board, and he will be termed as a learning disability when actually his problem is he cannot see the board, not because of his eye problem, but because of what is written on the board. Crowding on the board, he cannot read. So we have actually seen school children who are actually labeled as learning disability and SEND. And then you go back and take the history and you find that the child was actually a low birth weight child. And we did an MRI, we found that it was periventricular leukomalacia. Again, the child is actually going to school. So he's a school-going child. And his problem is vision and not learning. So it's a very important thing that you have to ask for. They have I mean, I don't, for lack of time, I don't want, but cortical visual impairment is something which you have to look for and you have to address.
Okay, sir.
How will you differentiate visual loss due to optic neuritis and visual loss due to cortical visual impairment clinically? Suppose optic atrophy is there.
Sir,
How can you differentiate clinically on test?
sir, primary and secondary optic atrophy.
No, you differentiate between optic atrophy versus cortical visual impairment.
Sir,
Consensual light.
Anybody else? It's simple.
So in cortical blindness, there will be lesion in the occipital cortex. In
Okay.
optic atrophy, and there will be lesion in the
Okay.
optic nerve.
Okay. Clinically, will you be able to differentiate both?
Light reflex.
Good. Yes. Pupillary reflex will be retained in cortical visual impairment. It will be lost in optic atrophy. Yes.
Yeah, you said global developmental delay in this child.
yes, sir.
What is the definition, and is it what is the age of the child?
So the age of the child is 7 years, sir. If two or more of two domains are involved, then we can tell it as global developmental delay, sir. But nowadays, after 5 years, this global developmental delay is termed as intellectual disability.
Global after.
Sir.
Yeah. You're not audible.
Sir.
You're not audible.
Sir, if
come again.
Two or more two domains are involved, then it's called as global developmental delay, sir.
Okay, what are the domains?
Sir, mainly gross motor, social, language, and fine motor, sir.
Gross motor, social, language? No, the gross and fine motor you put together into one domain. Motor, social, language,
special senses.
No, the other things are cognition and activities of daily living. Okay, so those are the domains which are taken into consideration. If two or more, or if there is involvement is significantly affected, you call it as global developmental delay. But it's used up to what
5
age?
years. 5 years.
5 years. Beyond that, how do you call that?
The intellectual disability, sir.
Intellectual disability. Okay. So this child is 7 years old.
Yes, sir.
Sir, are we right in calling it as a global developmental delay, sir?
Yes, the question, I can't answer that question because I don't know what is the development of the child.
Okay,
so
sir.
She has not really said this. So I don't really know what is the development, because you're saying that the child is writing alphabets. So that is quite good. That's about 6 years. So I will be very careful to call him global development delay. He may have a motor delay, but I would wait for some time to do a proper assessment before I call him global development delay. Definitely motor delay is there. He may have speech delay also, but learning may be quite good. Many of these children are quite good. So I will wait for an assessment before I call him a global development delay.
But regarding the age, child is already 7 years old.
No, that's what she wrote, some alphabets and all is writing. So
yes, sir.
So I think that is the thing, is maybe if he is given the right input, he may be doing well. He may be cognitively very good.
Yes,
he may not be able to walk, but he may be cognitively quite good. So I will wait. I will just wait for the proper assessment, and then I will wait. And then I will call. Then I will decide if he, after like Dr. Ramas said, after that we will do some formal assessments, and then we will decide whether he has got actually global development. I will wait. That is the thing. Definitely, I will say motor delay. Speech, I'm not sure because she didn't really mention the speech, but I will definitely wait before I call him GDD.
Okay.
There is a question here. Nikita, can you explain this? Because These are all words which are thrown in exams, but you should understand what these words are. Can you explain multidisciplinary treatment approach?
Yes, sir. It includes a team of a pediatrician for neurodevelopment, then ophthalmology, then
You have to be
ENT.
very no, Nikita. You have to be very specific. Who's the team? What do they do?
Sir, I can't.
You have to be specific to tell me who is the team. See, the reason I say these things is because these are actually the questions which really affect the child. This is what in future, when you actually a child with cerebral palsy comes to you, when you become a pediatrician, when a child with cerebral palsy comes to you, you have to actually tell the child, see, these are the things which we are going to do, and this is why we are doing these things. So you must tell me exactly who are the specialists and what exactly are they doing. 7-year-old child, let us assume this child has got a motor age of 9 to 10 months. That's what I could say, walking with support. We will assume that the child's got a cognitive age of 5 years or so, because I saw him write some alphabets. Language, you said what is he speaking language?
Sir, the common things which has been taught to him, like he's telling his sister's name.
So is he speaking in sentences?
Yes, sir. He's making some 2 to 3 word sentences, sir.
Okay, he's saying 2 to 3 word sentences, and so we would assume that would be what developmental age?
Sir, around 3 years, sir.
Okay, from whatever assessment, it could be 3 years. So he has a gross motor age of about 9 to 10 months,
yes, sir.
A language age of 3-4 months, 3 to 4 years, 3 years probably. Fine motor age of 5 years, I would say. Now, how would you manage this child? What is the multidisciplinary team involved in this?
Sir, as a pediatrician for a neurodevelopmental, sir, then a speech therapist and parents has to be included in that, sir, along with a physiotherapist and
what does a physiotherapist do? So each person, tell me their role. Don't say physiotherapist. Tell me what the physiotherapist will do. Tell me what the pediatrician would do. Tell me whoever other persons are involved, what exactly they would do.
Yes, sir. So pediatrician role is to assess the the pediatrician role helps in is a nodal person and is more important for neurodevelopmental screening, sir. He is also involved in growth and nutrition assessment.
If that is the role of a pediatrician, Nikita, you failed because that is something you didn't do. Anyway, continue.
Sir, psychologist will help in developmental evaluation, sir.
Sure. So you have a pediatrician, you have a psychologist, you have a physiotherapist.
Yes, sir. Physiotherapist will help in assessing the tone and power of the muscles, sir, and helps in training the child with the tone abnormalities, sir. If the child really needs any applicants of cast and all, they would be helping, sir. And occupational therapists, sir, they are also included. They will help in neuromotor coordination, sir, and also oromotor coordinations. And ophthalmologist, we have in case we have to rule out the ROP or strabismus if there is any refractory.
7 years, not
yes,
ROP, not ROP.
Any refractory errors, sir?
I'm talking about this child. What is the team involved?
So for this child, then a pediatrician has to be involved. Then early interventionist and physiotherapist, occupational therapist has to be involved, sir. Speech therapist has to speech therapist, sir.
You're right. I'll just say this. I'll just put it together if you want. So the pediatrician's role would be, of course, making pediatrician, pediatric neurologist, developmental pediatrician, whatever, anybody. The role would be primarily making the diagnosis of cerebral palsy. Again, you have to be very clear. Don't assume everything is cerebral palsy. Okay, we have a lot of slowly progressive disorders. We have genetic disorders. So many things nowadays which are coming up. So always be ready to change your diagnosis of cerebral palsy. This mistake has been made many times. I have made the same mistake, thought it was CP, it went on to be something else. So that is something which would always, the diagnosis is something that can keep changing. Maybe for the exam you can see CP, but in real life you have to keep an open mind. That is one thing. Of course, treatment of his nutrition, seizures, medical comorbidities. Vision would be probably the ophthalmologist would be involved primarily in making the diagnosis of a cortical visual impairment and strabismus treatment at this stage in this thing. Of course, EMT person, if there's a hearing assessment, you have to keep thinking. Once in a while, you have to keep looking. It's not just, you could have serous otitis media, which will affect their language. So that also something has to be done. Okay, so that is it. Now, the other team would be the role of this early interventionist, bar psychologist, anything. It would be first to make a formal assessment of his learning. What does he learn? How does he learn? And making a plan for his learning. This physiotherapist would be like what you said, mainly tone abnormalities, tone and power would be the role. And of course, gait is more in their area, gait things. An occupational therapist would be daily living functions, oromotor functions, which probably an OT or a speech will do. And a speech therapist mainly to make an assessment whether this child is going to be verbal or not so verbal. If it's not so verbal, the child will probably have to look for, some kind of alternate communication methods. And of course, once the child goes on, then it will go, once this is over, once you started early intervention, then would be school age. We may need in this period itself, you may need orthotics and prosthetics, which for helping the child to move. He may need to be splintered. If there's a problem, hands may need to be splintered. Then as a child goes on to school, special education, you may not need special education. That's also another thing. You may not need special, you may be a normal child, you may be able to go to normal school with some kind of accommodation, seating accommodation, visual accommodations, maybe pencil, grips, something. He could actually be a normal child. So please don't assume that he's a globally delayed child. And then of course, vocational or maybe even normal school. These are things which you could do. Of course, we should also think about this possibilities of ongoing psychological counseling. So you must remember this child can become a doctor. So you should remember that and give him the full abilities to become a doctor as well.
Nikita, you said gross motor functional classification. Can you name any other, a few more classifications for?
The manual ability classification system, mainly for Kollam, sir. And also we have classification for eating and drinking ability classification and communication ability classification system, sir. For and visual ability classification system, sir.
Okay.
And in examining a child, your evaluation starts as soon as the child enters your room. So the thing is, you may not be able to reproduce the same sign once again. Suppose the child is walking something, you are able to establish the action dystonia. Dystonia while walking, the child may not be cooperate. So you start examining as soon as the child enters your room. So by playing, by doing something, you can assess the development also. So you should keep it in mind so that you can save time in the examination.
Okay, sir.
Anything else, sir?
That's a very good point which you mentioned, sir, because everybody thinks that developmental assessment is something which you have to spend 10 minutes, 15 minutes to do. Actually, it's not that. Like sir said, developmental assessment starts the moment you start seeing the child. You give him some things, you give him some toys, he will write something for you, you're assessing his thing. You don't have to do a formal, if the child is able to write his alphabets, you don't need a visual assessment. You know that he can see. If he's answering your questions, he can hear. So you can, as you talk to the parents, you can listen what he converses to the parents. If you have some toys, see how he plays with those toys. So your developmental assessment is actually not something which is outside of your clinical examination. Even as you finish your history, you can do your developmental examination, and it's usually only all you need is mostly what you need is your eyes. Few things you may have to check with here. So you are going as you do it. So it is not separate. So it is not separate from your neurological examination. In fact, development is neurology. So your neurology examination is incomplete without a developmental examination.
Hello, sir.
Yes, sir.
Yeah, actually, Dr. Annamalai Vijayaraman sir asked one question. In a postgraduate exam of 40 minutes, please tell what are the essentials in clinical examination and possible besides history in that limited time. It's Dr. Annamalai Vijayaraman.
Dr. Mahesh, I don't really examine postgrad, so I think there are other people better than me to answer the question.
Sir, usually, sir, if the candidates use it, they should make it as a habit to repeatedly ask history and examine the child and write case sheets. So whenever they are doing it repeatedly, the time duration reduces. So they are conversed with suppose first, second, or third time, they may be finding it difficult to take some detailed history. It may take even more than 1 hour. Next time they know what to focus. So while taking history, they can watch the child, they can make the child play, and then the child may be sitting something. Suppose the child is 3 or 4 years, maybe doing something, you can watch whether the child is having spasticity or not, child is having ataxia or not, whether there is any dystonia or not, whether dystonia person at rest or while doing action or there is any tremor. All these things can be made out while taking the history alone. The recently concluded DNB examination, few of the candidates were saying when they have completed the paraplegia, while taking history, they can in 15 or 20 minutes they took only history alone, but they were able to manage because they have already seen the case while taking history. That should be the attitude. So gradually, by repeated training, by practice, they can make it out.
Okay, sir.
And it differs from each and every patient, sir. Suppose for some patients, some clinical findings are what they should highlight. For example, in the spastic diplegia, they should be focusing there is no localizing level. Suppose the same spasticity can be at dorsal level. So the candidate should be keen to demonstrate that there is no localizing sign in this case, like that. Yes, sir. So unmute.
So as the other examiners have been saying, should happen simultaneously. The history taking along with the examination should happen simultaneously. I've noticed postgraduate sitting and getting a detailed history for about 30 minutes and then running severely short of time for the examination. So just a brief history to know which track to follow, then examination. And I would like to reiterate that this unstructured play, that is, the child, if you knows that you're watching, it will inhibit certain activities of the child. So once you've got the history, you can allow the child to play in a mattress along with the mother, and you can observe a lot of things during that time, the way the child approaches the ball, the playing of the hands, it just does not finish with just reaching out for object, how exactly the child is reaching out for objects. And those are the things that you can watch if the child is allowed to do it uninhibitedly. So I think for a development case, that we have to spend 5 minutes on just observing the child without the child realizing that. I think that will give us a lot of...
Can I make a comment?
Yes, sir.
Yes,
Can
sir.
I make a comment?
Yeah, please, sir.
Yeah, it's the tendency of the students, usually PG students in the OPD or whatever, when a CNS case, especially cerebral palsy comes, they try to pass it on to the other person. They try to show more interest in cardiology case or some other case. So malnutrition, cerebral palsy and all, usually because it takes so much of time in the routine OPD and examination, it's passed on. That's why, that practice is very important, that at least 10 cases in the 3 years, you should be able to examine. And observation, as you mentioned, emphasized by everybody, as you are taking history itself, we can observe so many things about the movements of the child, etc. Thank you for allowing me to make some comment. Thank you.
Nikita, can you stop your slide sharing, please?
Yes, sir.
Yeah, Dr. P. Ramachandran, sir, please.
Thank you, sir. It was a very interesting discussion, and with a lot of good inputs from all the teachers, and the students are also faring very well, giving all the important answers. So the general comments, what the examiner's point of view I'm talking, is not about this particular child as such. They want you to talk more in total assessment of the child and how you are as a pediatrician, along with all the others, how you are going to manage this child. So for that, they would expect you to take into account all the family background, financial, and what are the facilities available for them, what they have been doing. So even those things have become very important. And is there any financial assistance they are getting? Have they registered the child in district early intervention program? Even those things will be asked as a pediatrician. The second aspect is, as Dr. Mahesh said, this comes with repeated practice. As somebody says, it's not because you are 60 years old, you are a senior pediatrician. You should have done 1,000 times the percussion. Only then you become a senior pediatrician. Same way, you have to keep on doing all this clinical examination, neurological examination. Even you can take even a normal children, do it in a systematic way, ask somebody to observe it, whether you have missed or done all the things. So it comes with repeated practice, then it becomes second hand. What the examiners could maybe doing in the actual clinical examination is take you to the child and just ask you to demonstrate a few things, like how you look for a tone, how you look for the way you handle a child, they know whether you have done this repeatedly or not. That is what the examiners are looking, the competence skill within that short span of time, other than the way you move with the child, take the history and the mother, how you are empathizing and all that. This is what they may be looking at just to assess whether you are doing it okay. Because from an MBBS level, here they expect you to be much more competent. So that may be another thing. And with time, with practice, it comes, you can do it definitely very easily. As you have done,
more comment
all
I
the
want to
students have
make.
done well.
Yeah.
Sir, go ahead, sir.
I want to make one more comment. You must always, find out what are the good prognostic factors and poor prognostic factors. The examiners will always ask. For example, microcephaly, or the child is having other morbidities like hearing impairment, etc. The stimulation will not be there. So these are the things which you have to really find out, and that because you may have to counsel. The counseling is also there as part of the examination, and you may have to tell the parents why physiotherapy, occupational therapy are very important for improvement of the child. And you should tell these are the positive things in your child. So definitely you should go ahead and then this thing. That type of counseling is very important. Thank you.
Dr. Ramesh,
As Dr. Samuel was telling, to know the etiology, you should probably dwell on the initial period, what are all the things happened. In this child, there is a big gap. At birth, 34 weeks, which is not very bad, and not much of before delivery, not much of problems and other things. And not so much preterm, but this child required ventilation and other things. What is a 15 days period? What are all the things this child did, if the mother knows? Those things are very important. She might be visiting the most at the NICU. How was the child? Was she told anything? Did she observe the child's head was smaller compared to the previous child? These are the questions which will tell you that whether the problem was related to perinatal or something even antenatal. You might get some clues. Okay, so you should dwell on the initial period is the one which will give you the regarding the etiology. Later will give you this thing about the child's status, progression, and other things. So don't miss that first initial period till they came to you to the hospital. That is very important. Thank you.
Dr. Ramesh, sir.
Yes, sir. Neurological examination is tiresome both for the patient as well as for the examiner. And expecting a young postgraduate to do a complete and thorough neurological examination, including developmental assessment in 45 minutes, is too much. So how they should train is more important, because compared to postgraduates of yesteryears, maybe two or 3 decades ago, when there were service postgraduates or older people who are taking them after experience, practice, having children. So their understanding of growth and development was much better. Now the young postgraduate have poor exposure to that and have difficulty in understanding the growth and development. So what I tell my postgraduates is, on your free days or on your admission days, keep small children of different months and age. Like for example, first 2 months baby, observe it for 1 or 2 hours every day. Even as you are writing or you are reading some books, keep a mother on a lap by the bedside, and then I keep observing how the child mother interact. Like the next admission, the next opportunity, 4 months old child, then 6 months, 9 months, like that. If you have to experience, because only practice makes perfect. And another thing is, as Professor Samuel said, earlier days, anything that was the child as spastic was only cerebral palsy. It is not so nowadays, because earlier on it was a clinical diagnosis. There were no CT, no MRIs, and so no further evaluation was done. Now it is possible we are going to a molecular layer, including assessment of enzymes, inborn errors of metabolism. So many newer syndromes are being diagnosed. So always have it in mind that if it is not CP, what else it could be. So make a thorough analysis, do the investigation possible, as Samuel was repeatedly selling. If the mother has all the money in the world, what are the investigation you will do? Like that, people can afford. We don't decide that they are poor, they cannot afford, or they cannot go to a corporate hospital or cannot go to a cosmopolitan city. They are always willing to make their child all right at any cost. So always make it a point to have a thorough examination, think of all the possibilities, do the complete evaluation, and especially postgraduates. I have noticed postgraduates in different examinations, they stop developmental assessment with history alone. They should carry a kit which contains the object that will be appropriate to assess the 4 domains of development, and then they should perform it at leisure in the ward or on their duty days or admission days or OP days when the crowd is less, and learn. Practice always makes for. That is my advice to the young postgraduates. Thank you, sir.
Thank you, sir. Next, Dr. Janani, madam. Okay, sir. Yeah, Dr. Samuel, sir, final conclusion, sir. So, unmute, sir.
Thank you for this opportunity. Actually, I don't, because I'm working in developmental pediatrics, I really don't deal with postgraduates. I've never gone for a postgraduate exam. But my point is this: unfortunately, we are moving. This is something which I want to tell all postgraduates. It is not, the exam is not the end of things, and you are actually, it is, you have to, and I think we are limiting ourselves by thinking the end of all things is the exam. It is not the exam. A child in front of you is important, and we have to think in terms of the child. And let me tell you, as a developmental pediatrician, nearly 10% of the children that you will see will be developmentally compromised, will have developmental delay, and with autism and things rising, that is going to be the most rapidly increasing number of children. So you have to do it. And most of the things which, again, I keep saying this, in 2200, if we are not going to be alive, but 2 things will always stand: history and examination will always stand. There will never come a time when history and examination become outdated. And like Dr. Mahesh said, most of our diagnoses we have already made during examination in history. We corroborated with the examination. So history and examination has to be given utmost importance. Even small things like head size, these are all very, very important things. And most of your diagnosis can be made at that history and examination level. Only if you do that can you order the right investigations and go on to this. So that the take-home message, if anything, from my side, is history and examination remain the key. Thank you.
Thank you, sir. Dr. Mahesh, sir.
Thank you, sir. Nice presentation. The thing is, I want to stress on the history and clinical examination. Whatever they see, they should correlate. Suppose there is any spasticity, whether it is correlating with our clinical diagnosis or not. Suppose there is spastic diplegia or erector spasticity, whether it is correlating with the clinical presentation. So they should make additional clinical signs. So they don't fix their mind with a CNS presentation alone. For example, sometimes there will be additional cardiac findings. So what they should explore more. The thing is, by the time they see diplegia, they should not think that it's only CP. So they should think other causes and rule out and then come to the diagnosis, because they should look for a treatable cause in a non-treatable condition. Thank you, sir.
Thank you, sir. Dr. Ramasubramanian.
Yes, sir. Sir, as all the seniors have pointed out, it's repeated practice and case presentations which will help you in the examination. So thank you, sir. Thank you on behalf of Department of Pediatrics, Saini Medical College, for giving us the opportunity to present the case. And I thank the other panelists and other judges, senior people, and also the PGs for presenting the case. Thank you, sir.
Thank you, sir. On behalf of IAP TNSC, I thank today's chairperson, Dr. Samuel Oman, in spite of his busy working hours. He has participated our IAPT NSC teaching program. Thank you, sir. And I thank Dr. Magesh sir for his immense contribution. I think he's participated second time in our postgraduate teaching program. Thank you, Dr. Magesh sir. And thank you, Dr. Ram Subramanian. You have prepared your postgraduate very well for presenting this case. And thank you very much. I thank all the judges, Dr. Srinivasan sir, Dr. P. Ramachandran sir, Dr. Rama Chandramohan sir, madam, and Dr. Ramesh sir from Chidambaram, and Dr. Janani madam, who are participating all the postgraduate teaching program. And it's the awarding mark also. It's, again, it's encouraging our postgraduates to make this presentation very well. And I thank all the postgraduates today participated and presenting a very nice case. And I thank Dr. Nikita, who has presented really very well. And I thank all the students as well as teachers all over India. Almost 600 to 700 persons they were watching every week. I thank all the faculties as well as students, and thank DIP Sweta, who has given our thank you very much, sir. Thank you.
Thank you, sir.
Thank you. Thank you, sir.
Thank you, sir.
Dr. Rajendran sir.
Sir, please.
Sir, as I told in the previous meeting itself, I think the students, all the 3 students should sit separately and they should actively participate in the discussion. They can come with the questions, they can come with the doubts, they can ask. And again, they should show their face. This time they didn't show their faces.
Okay,
Thank
sir.
you.
I will next time I will make it, sir. Thank you, sir. Thank you.
Thank you. Thank you. Thank you.